Welcome to Session 3 of the PneuBack program, Level 1. In this session, we'll be going through the Vibro Trac table, including some of the theoretical work behind the table and the procedural work as well. Please ensure that you have fully read and understood the manual and that you have the manual available as we go through this webinar, as you'll need to go and have it for reference. When we're looking at the entire PneuBack program, the Vibro Trac table actually comes in step number 2 after the posture map. It is important to keep the Vibro Trac table in this position, as when we start to see patients, it actually becomes the first piece of equipment that in the second visit onwards the patient will be on. The Vibro Trac table is integral to the work that is done, and it's extremely important that it always be at the start of the patient visits, because we know that the vibration increases vasculature, meaning that we can get more blood flow into and out of an area. We also get more lymphatic movements with the vibration table as well. So oftentimes when you start to see a patient for the first time who's in acute or chronic pain, there will be specific regions of swelling and inflammation, and the table is very important as a first step to help to not only relax the muscles but remove these areas of inflammation. Furthermore, we know that utilizing a vibration platform excites the proprioceptive receptors within the back and relaxes the muscles. This will allow us then to make corrections in an easier fashion, and as a result then we're able to strengthen around those areas and utilize the new corrected area as a set point for the muscles to strengthen or fire around. So remember that when we're looking at the Vibro Trac table, on the very first visit, it is step 2 following the new map. On the second and following visits after that, the Vibro Trac table is the first piece of equipment that the patient will be placed on. If we take a look at disc herniations, we will talk a little bit about what we see in the theoretical ideas behind the way that we do correction on a patient with a disc herniation. Most patients, when they have no disc herniations, as we see in this example, the spine is relatively healthy and the disc space is even between the front and the back and the left and the right. No wedging is noted in this picture, and you can clearly see that the nucleus pulposus is sitting right in the center here. If a patient has a disc herniation or some sort of injury to the disc itself, where we either get a bulging or protrusion, in this example along the right posterior side, then what we tend to see is the nucleus will shift towards that area, and there's going to be a wedging or a compression or loss of disc height on the front opposite area from where the disc bulge will be. In this case, it will be the left anterior side. As the nucleus then shifts over to that side and there is either a bulging of the disc or there's herniation of the nuclear material, there will be chemical irritation along the nerve roots itself and not necessarily just the mechanical impingement. This can cause problems like radiculopathy along with pain and discomfort for the patient. The chemical irritation will also cause localized swelling and start a pain cascade that can eventually result in loss of function. When we utilize the Vibro Trac table, what we're doing then is we are applying a very specific traction force. In our example then, the traction force will be on the left anterior portion of the disc where the wedging was seen. By opening up this area, we're almost creating a sucking area or a vacuum in the disc, whereby it will pull the nucleus itself forward and back towards midline. By being able to do this, then we can reduce any bulging of the disc in this area. We can also remove any form of swelling, inflammation, and reduce the irritation along the nerve root. By being able to move the nuclear material and move the nucleus back towards midline, this is something known as the billows effect. By doing that, then irritation is removed from the nerve root, and problems such as pain in the back and radiculopathy down the leg can also be resolved. As we look at the Vibro table, there are certain very important features that we need to keep in mind. The first is that the table itself has only one vibration component, and that's right in the middle of the patient. This is going to be important to remember because as we place a patient on the table, we want to have this component up and on the vibration plate. We always recommend utilizing a roll or a soft pillow underneath the patient's head to isolate the vibration from causing the patient any pain or any discomfort. And the other important parts to remember are the four quadrant or the four pulling arms in each quadrant. Depending on where we attach the strap to these pulling arms, whether it's at the top ring, the middle ring, or the bottom ring, we can pull harder or we can pull less on the patient in that specific region. As we're putting these on, one of the things to remember is that the lower you attach the strap, the harder the arm will pull. So if I attach the strap down on the middle one on the right-hand side and on the lower one on the right-hand side and go to the middle or the top one on the left-hand side, it will pull harder on the right side versus the left side. One of the things that we've been working on with patients is to utilize a sacral wedge. The sacral wedge was originally designed for patients with hyperlordosis, spondylolisthesis, or anterolisthesis with wedging of the lumbar discs, patients with pain on extension, or patients with pain with laying flat on their back. However, what we have found is that for most patients, it's actually more comfortable to utilize the sacral wedge. So the sacral wedge is now recommended for almost every patient, with the exception of patients who have reverse lumbar lordotic curves, or more specifically, patients with pain on flexion. If you are uncertain whether your patient should be utilizing a wedge or not, if they feel no pain with flexion, then we recommend utilizing the sacral wedge. 9 out of 10 patients will tell you that it's more comfortable to have a sacral wedge when being placed on the Vibro table than without. The wedge placement is simply in such a way that the high side of the wedge goes underneath the sacral tip and the low side of the wedge will go underneath the sacral base. Now the Vibro table has several different protocols and it can be utilized for different problems. These problems include the right and left posterior disc with no radiculopathy, the central discs with disc herniations with no radiculopathy, right and left radiculopathies, spondylolisthesis, and low back sprain/strain. The important thing to keep in mind then is that these are separate and different protocols for each patient and each problem. So not every patient is going to need to go through each and every one of these protocols. They will only follow the protocol that they need based off of the initial evaluation you did with them and where their area of pain and problem is. Now remember that the different components of the protocols might be slightly different, but each of them actually have certain overriding factors that are similar. So if you keep an eye on, as we run through the protocols, where the strap is placed for each quadrant, so the location that it's put on each arm, whether it's the middle, top, or the lower ring, where on the D-ring or the waist belt we attach the strap, which side the clinician stands on, and what mobilization direction is used, then you can pretty much figure out which protocol is used to do what. So as we go through this, keep those 4 things in mind and try to keep track of them as we go through explaining how to do each protocol. After the different protocols that you see here, whichever one you will do on your patient, you always will finish off by utilizing the ball exercises after each one. So if you're doing a right posterior disc with no radiculopathy, after you've set up and done the mobilization, you will do the ball exercises. If you have a patient that requires a central disc protocol with no radiculopathy, after you've done that, you'll go and do the ball exercises and so on. If you have patients with multiple problems and they have more than one area of, say, a disc herniation, then what we would recommend you do is to find where the main area of complaint is, what the symptomology will be, and approach that first. If that does not resolve the problem, then go after the secondary problem that you might see. So even if the patient, even if say you have an MRI that shows that a patient has a central disc bulge and a right posterior disc herniation, if you go after the right one because they're complaining of pain down the leg, but that does not resolve the pain down the leg within about 2 to 3 visits, then switch and start doing a central disc and see if that helps to resolve the problem. We're going to start today by going through the right posterior disc with no radiculopathy. In this case here, then remember the 4 things we're going to keep an eye on, and they are pretty much listed here. One is where is the attachment of the ring on the table, or of the straps on the table, and in this case at the foot of the table then, once the patient has the vest and the belt placed on them, then we will start to figure out where to put the straps. Now before we go into the strapping, let's review real quickly how to put the vests on the patient. There are different vests that are available for utilizing and doing work on the PneuBack equipment. When we're utilizing the vest for the table, we will always use a sports vest. And the difference between a sports and a vectors vest is that a sports vest has no clips along the back. So you can utilize a vectors vest to do the work on the table. However, it may be uncomfortable for the patient to lay on those clips. Furthermore, if you're going to be using a vectors vest on a patient, we'd recommend that you unclip the straps for when they are on this table. The other part that needs to be placed on the patient prior to putting them on the table is utilizing the waist belt. As you can see on the waist belt, there are actually 3 D-rings on either side. One is right in the middle, one is right in the front, and one is in the back. We will always want to place the waist or the pelvic belt so that it sits lightly above the iliac crest on the patient. So in this picture, the belt should actually be slightly higher. We also want to make sure that the belt is centered such that the middle D-ring is going to run along midline of the patient's thigh. There are different sizes for the belts themselves. The red is considered small, the blue is considered medium, which would be appropriate for most adults, and the yellow is considered large. There are smaller belts and there are larger belts available for special cases. When placing the harness on the patient then, we always will recommend that you put the pelvic belt first and then the harness second. And make sure that before you tighten down the harness, that the pelvic belt D-rings are available and that they're easily accessible so that you can clip the straps to them. Make sure that both the harness and the pelvic belt is tightened down snugly such that there is minimal movement, and the harness needs to be placed such that it will grab right underneath the rib cage. In certain cases, the harness will overlap the D-ring belt and there is no way to get around that. When that occurs, what we will do then is we will loosely attach the harness to the patient with the pelvic belt on, have the patient lay on their back, unhook the harness itself, attach the strap to the pelvic belt before tightening down the harness. For more information on utilizing the different harnesses, please refer to our session on utilizing the different vests, as this will give you a better review as to how to attach the harness itself. If we go back now then to looking at the right posterior disc with no radicular pain protocol, after we've got the harness and the belt on the patient will be laying on their back. At this point in time, we would recommend putting the sacral wedge down. Once that is down, then we're going to start attaching the straps from the foot of the table and at the head of the table to the patient. At the foot of the table then, the tension strap will be attached to the top position on the patient's right side and to the bottom position on the patient's left side. Again, keep these straps nice and tight. When we're attaching to the pelvic belt then, the other end of the strap will go on the right side to the patient's neutral or posterior D-ring. On the left side will go to the anterior D-ring. At the head of the table, the strap will attach from the harness itself to the top position on the patient's right and to the bottom position on the pulling arm on the patient's left. After this has been set up, a 55 centimeter ball will be put under the patient's legs to form roughly a 90 degree here at the pelvis and 90 degrees here at the knees. If we quickly stop at this point in time and think about what we have done, we're looking at a patient with a right posterior disc bulge, in which case the herniation has gone to the right and back side of the disc. By thinking about our model, with the disc and the nucleus moving to the right posterior quadrant, it means that the left anterior quadrant has wedged and that the height of the disc has compressed on the front left side. So by doing all our connecting on the table here, where we're on the lower ring on the right side, or excuse me, on the left side, and we're on the lower ring on the left side here, we are actually going to be pulling harder on the left side. By attaching to the anterior D-ring on the left side, we're going to be pulling at the front of the disc harder on the left side so that we're going to open up the compressed area. By doing that, then there's going to be the billows effect, which will pull the nucleus closer towards the middle. Vibration and traction will be turned on to approximately 20 hertz and about 10 to 20 pounds. In general, this will be true for each and every procedure that we go through, so it's something that you can just keep in mind, that if you're running 20 and 20, that will always be the setting, both hertz and pounds. Initially, we will let the patient lay on the table with the vibration and the traction going for about 2 to 3 minutes prior to doing our mobilization. The table is typically set to start the traction and keep the traction pulling for 45 seconds and then shut off after 15 seconds. It will then start again for 45 seconds and then shut off for 15. When the mobilization comes on, there is a light on the control panel. Once you see this light come on, then we start to do our mobilization force. For a right posterior disc, the patient stands on the clinician stands on the patient's left hand side. They will place their right hand on the patient's bottom left thigh. Their left hand, clinician's left hand, will go on the patient's left ankle. And when the traction is on, then the mobilization is accomplished by pushing with the right hand downwards towards the foot of the table, and the left hand will go medially in towards midline. As a result, the traction force or the mobilization force will be down away from the head and medial. It'll almost be a J shape. When we're doing this mobilization, we'll hold the mobilization for 10 seconds and then rest for 2 to 3 seconds and repeat approximately 12 times. Again, if we review the system of where we were and what we're doing, if we're looking at a patient with a right posterior disc bulge, the disc material has gone out the right posterior side. It has wedged along the left anterior side. We're going to be pulling harder on the left side to gap open. At the D-ring belt, we're attaching to the anterior of the left side. Our mobilization then will be at the left side, and what we're going to do is we're going to pull down and go medial to gap open that left anterior side. So everything that we're doing is very specific to the quadrant that needs to be opened. The left posterior disc protocol with no radicular pain is very similar to the right, except now we're going to be focusing on opening up the right anterior portion of the disc. As such then, when we're at the foot of the table, we're going to attach the strap to the right lower ring, and the left side is going to be on the right top ring. When we're looking at attaching the strap to the patient on their D-ring belt, remember we want to open up the right anterior side, so then we'll go to the right anterior for the D-ring, and we will go to the left neutral or posterior on the left-hand side of the pelvic belt. At the head of the table, again, we want to open up the right anterior side, so then we will pull harder on the top right quadrant, and we'll pull less on the top left quadrant. So we'll go to the top attachment there. Again, a 55 centimeter ball is placed underneath the patient, and the machine is turned on starting at 20 hertz and about 10 to 20 pounds of pull. Make sure the patient feels no pain or discomfort and allow the patient to relax while the vibration is running initially for approximately 2 to 3 minutes prior to starting any mobilization. So we're looking at a patient with the left posterior disc bulge here then, according to our model. As the nucleus goes out through the left posterior side, it's going to wedge on the right anterior side. Our setup is such then that we're going to pull harder on the right side, and we're going to pull harder on the right side. We pull less on the left side, so the clinician will stand on the right side. We're pulling on the anterior to open up the anterior of the disc itself. The clinician will then place their left hand on the bottom of the patient's right thigh and their right hand around the patient's right ankle. Mobilization then will be done by having the clinician push away from the head and towards midline, and you get again a characteristic J motion when you do the mobilization. We hold this for about 10 seconds, rest for 2 to 3 seconds, and repeat 12 times. So remember, what we're doing is we're targeting for an area where the disc will be compressed on the anterior right side, and everything that we're doing is to open up that right anterior side where the disc has compressed. When we're dealing with a central disc bulge with no radiculopathy, what we want to do is we're not going to specify left harder than the right, so all the attachments are going to be relatively neutral. So when we're looking at the foot of the table, we will attach to the neutral or the medial position on the rings on both sides. Remember, we're not going to try to pull harder on one side versus the other. Same thing when we go to the top or the head of the table. We're going to go medial because we want to pull evenly on both sides. Now the only difference is on the D-ring then, we will either pull both at the neutral position, or we will pull both sides at the anterior. So remember, with the posterior central disc bulge, the herniated material has gone out through the back and you're getting a wedging at the front of the disc. So if we attach to the anterior D-ring of the waist belt, it will actually start to pull that disc open. 55 centimeter ball is placed underneath the patient, and we will turn the machine on starting at about 20 hertz and 10 to 20 pounds of pull. Allow that to run for about 2 to 3 minutes prior to mobilization of the patient. When we mobilize the patient in this scenario then, what we want to do, remember, is we want to gap open the front of the disc so the clinician actually stands at the foot of the table. They will grab both feet and lightly pull the patient such that the mobilization is they're going to pull the feet towards them and down and over the ball. So when the traction is starting to pull, the clinician then will hold on to the feet, pull towards them and down and over the ball, hold it for 10 seconds, rest for 2 to 3 seconds, repeat 12 times. Again, the whole setup for this then now is that we're going to try to gap open the anterior portion of the disc itself. When we're dealing with the right radicular pain, what we're looking at here now then is that we're not so much looking at pulling open the disc, rather than we want to start to gap open some of the SI joint. In this respect then, what we saw with doing the disc herniation work, where the clinician stood on the opposite side of the problem, with the radicular symptoms, we will always stand on the same side of the problem. So with the right radicular pain, we want to pull harder on the same side. So what we'll do then is that with the patient set up at the foot of the table, strap will be adjusted to the right side. This is the affected side at the bottom, so we can pull harder, and it'll be at the top for the left side. When we're looking at attachment to the D-ring, we're going to go neutral or posterior on the left side, and then we're going to pull posteriorly on the right side. So when we pull posteriorly on the right side, we're going to rock the ilium back just a little bit and gap open that SI joint. At the head of the table, again, what we want to do is we want to pull harder on the right side, which is our affected side. So we'll attach to the bottom ring of the right side and the top ring of the left top arm. 55 centimeter ball is still placed underneath the patient, and the vibration or traction is going to be starting at 20 hertz, 10 to 20 pounds. Again, we want to always make sure the patient feels no pain or discomfort, and all the settings are pretty much exactly the same, where the interval will be on for 45 seconds and then off for 15 seconds. Allow the patient 2 to 3 minutes to get used to the machine each time prior to starting to do your mobilization. In this case, mobilization is done with the aid of a belt that will wrap around the patient's affected side. With the right radicular symptoms, we always will go to the right side. So then the clinician is standing on the right side. However, in this scenario, the clinician is going to be facing the patient's head. So the clinician will turn their shoulders such that they are roughly facing the patient. We loop one end of the belt around the patient's thigh, the lower portion of their thigh, and the belt goes down and around the clinician. And what the clinician will do then is, once the traction arms are starting to pull, the clinician will actually lean back at about 60 degrees away from the table and away from the patient's head, and they will hold that for approximately 10 seconds, resting 2 to 3 seconds and repeating 12 times. In this scenario, the patient will actually feel a gapping type sensation along their right SI. When doing the left radicular pain, again, the difference between this and doing a disc herniation is then that you're going to always be on the side of the pain versus the opposite side. So attaching the strap to the patient, then we're going to gap open the left SI in this scenario. So then at the foot of the table, we will pull harder on the left side, so we'll attach to the bottom ring, and we'll pull lighter on the right side, so we'll attach to the top ring. When we're looking to gap the SI joint then, because this is the left, we want to go to the posterior D-ring on the patient's left side. Again, that will rock the ilium back just a tiny little bit, and we'll primarily try to shoot for the neutral position on the right D-ring, or on the patient's right side. At the head of the table, we still want to pull harder on the left side, so we'll go down to the left lower ring at the left quadrant, left upper quadrant, and we'll go to the top ring on the right upper quadrant. Place a 55 centimeter ball under the patient's feet as you would, and start the traction at about 20 hertz, pulling at 10 to 20 pounds. Allow 2 to 3 minutes to let the patient accommodate and get used to the vibration and the traction before starting your mobilization. Make sure that the patient feels no pain or discomfort at this point. When we're doing the mobilization for the left radicular, it is similar to the right, except now the patient or the clinician is standing on the patient's left side. The belt is again looped down along the left thigh at the base of the thigh and then around the clinician. What you will have the clinician do is that they will face towards the head of the table, and they will, when the traction is on, lightly lean down and away from the patient's head, holding for approximately, or pulling out at about 60 degrees, holding for about 10 seconds with a rest of 2 to 3 seconds, repeating 12 times. Ensure that the patient feels no pain or discomfort as you're going through this. Once the mobilization is done in this portion, as we would with the other all the other techniques for utilizing the protocols for the table, remember the the ball exercise is always the next step. When you're looking at a patient with a spondylolisthesis, the general setup then will be to have the patient laying on their back with the harness, and it's extremely important at this point in time that the sacral wedge be in place. If the sacral wedge was not used before, it must be in place now. If it was used before, then keep the sacral wedge where it needs to be. When we're pulling for a spondylolisthesis, the important thing that we do not want to do is we do not want to bring the patient into extension. We want to put the patient into a flexion type position, which is why that sacral wedge is so important. At the foot and the head of the table, we will go neutral, as we do not need to pull more on one side or the other. And on the pelvic belt, the attachment will be either at the neutral D-ring or the posterior D-ring, with both sides being set in the same position. So if on the right side you put it in the neutral D-ring, put it in the neutral position for the left side as well. If you go to the posterior and you pull posteriorly on that pelvic belt, it will further place the patient into a flexion position, which for many patients with spondies will actually feel better for them. Remember to place the 55 centimeter ball underneath the patient. In a lot of spondy patients, you will have to be relatively careful and slow moving when you're placing any component under them, anything that requires them to move the spine. Turn on the vibration to about 20 hertz at about 20 pounds and let it run for approximately 2 to 3 minutes prior to mobilizing. Make sure that there is no pain or discomfort on the patient. When we're doing the mobilization, we put here follow the outline protocol as per needed by the patient. That would mean then that if, say, you have a patient who has a spondy and a right posterior disc, then we would start to do the mobilization for a right posterior disc, being extremely careful. We could also do the central disc protocol if that's what they have. However, if you have a patient that does not have a disc problem but has a spondylolisthesis itself, what we would recommend then is setting up as outlined here and doing some real mild, gentle mobilizations bilaterally, similar to what we would do for a patient with a central disc bulge. Please ensure that the patient feels absolutely no pain or discomfort as you're going through the protocol. You would still hold for about 10 seconds and repeat about 12 times with a 2 to 3 second wait in between. On patients with low back sprain strains, the most important thing to remember with a low back sprain strain is that there's actually no component that will utilize the harness or the belt. So what you actually see in this picture is misleading, because a patient who does a low back sprain strain protocol will not have the belt, they will not have the harness, and they will not utilize the D-ring. There's no traction component on a patient with a low back sprain strain, as the traction tends to cause more problems for a patient as they try to react against it. We will, however, still utilize a 55 centimeter ball underneath the patient's leg, and we will still utilize the vibration at 20 hertz. Remember, no traction is utilized in a case of a low back sprain or a low back strain. We will allow that to run for 2 to 3 minutes as normal, and the protocol for utilizing the low back sprain strain then is that the patient will be given a little ball, which is what you see here, and they will be asked to locate where they feel discomfort along their back. With that little ball, then they will place the ball on the area where they feel the pain or the tenderness, and the patient then will be lightly rocked side to side. And so they will slowly roll left to right, up and on that ball and then off that ball until the discomfort diminishes and gets less and less and less until the tenderness is completely gone. This procedure will then be utilized by the patient until each and every tender spot that they have has been addressed. So remember, when you're looking at doing a sprain or a strain, there is absolutely no traction component to this at all. With each of the protocols then that we have reviewed, following the mobilization component of it, you will always do ball exercises. Remember, the only protocol that does not use any traction, that does not utilize the belt, that does not utilize the vest, is the sprain strain. And in this case, we have a patient who's demonstrating doing the ball exercises. The ball exercises are utilized to initiate the reciprocal inhibition, whereby we can fire the abdominal muscles and the oblique muscles, and much in the same way as you would bend your elbow. When you bend the elbow, the bicep will fire, the tricep will relax. The same thing will occur here, where by firing the abdominals and obliques, the lower back muscles at the back of the spine here will actually relax. And this will be important for patients with chronic and acute back pain, as oftentimes spasms are present. So doing the ball exercise, it's the same procedure between the strain and sprain as well as the others, except in the sprain strain there's no harness and there's no traction component. But we will keep the vibration running for this patient. They start off by putting 2 hands on the ball, and what they want to do is they want to push in towards the ball here. You'll notice that the 55 centimeter ball underneath the legs has been removed and put up and on top of the stomach for this part of the exercise. If there was a wedge underneath the patient, we would keep that wedge underneath the patient. It will not be removed. knees are bent to about 90, and the right size for the ball is such that the arms will be coming almost straight out perpendicular to the table. If the ball is too small, the arm will be angled down. If the ball is too large, the arms will angle upwards. If the ball is too small, you can actually put a pillow or something along here until you get the correct size. So you want to make sure that the ball is the right size for the patient. So what we would do is have the patient slowly push in both arms. Palms are up and off the ball to prevent them from just pushing with their palms, and the ball rests right on the forearm of the patient. The patient will slowly push in, hold for 5 seconds, and then slowly come out. Oftentimes we see patients push in slowly and then just let go and the arm bounces back. We do not want that. So remember, slowly push in, hold 5 seconds, slowly push out. Repeat this 12 times. After one side is done, what we will do is we'll ask the patient to drop their one arm and keep the other arm where it is. So it should be off to one side, not in the middle. It's off to one side. The patient then will go ahead and push, but this time they're going to push from one side towards the opposite knee. So if this is the patient's right arm, we're going to ask them to push towards the left knee. When they do that, they're going to hold it for 5 seconds. Again, nice, slow, controlled contraction, and then a nice, slow release out of that. Again, repeating it 12 times. Once they've done this, we do the opposite side. In this case, we're folding the right arm, and the left arm comes up. They're going to go ahead and slowly push in towards the right knee now. As they do that, they'll hold for 5 seconds, and then slowly come out. Repeat for 12 seconds. During this whole time, vibration is left running. If the patient is doing any of the other protocols with the harness and the traction and the harness is left on the patient as well. This is the ball exercise then. Again, you will repeat this, or this is just another view of the ball exercises. When we're doing both hands, you can see then that the hands and the palms are up and off the ball. Hands are off the ball, and the patient actually pushes down on both sides, holding that for 5 seconds, repeating it 12 times. Remember, do not allow the patient to rush or push too hard. Okay. When you're doing the other ones, then if they have their right arm on the ball, they push towards the left knee. If it's the left arm, it goes towards the right knee. So the importance of this is to initiate the muscles. It's not about how hard the patient can push. It's also about control. Patients should feel no pain or discomfort when doing the ball exercises. Should they feel discomfort, say when they're doing the right arm, then you can go ahead and stop and move on to the next session. So if they've done the bilateral, so the two arms pushing and the ball exercise, no problem, they go to do the left side. The left side causes them problem after doing 3 repetitions. That's all they need to do. Go to the right side. If they feel no pain with the right, then finish doing the 12 repetitions. If they feel pain after, say, 5 or 10 repetitions, then stop right there and the patient is going to be done. At this point in time, then, what we will do is we will remove the patient from the Vibro Trac table. Typically, we will recommend that you keep the vest or the harness on. However, in some cases where you need to do posture corrections, you may have to change vest to utilizing a Vector's vest. The pelvic belt will no longer be used once the patient is up and off the Vibro Trac table. Now, when you're moving a patient from the Vibro Trac table and getting them up and off the table, usually we will recommend that somebody helps the patient up. We ask the patients to roll to one side and push up with their elbow. If the patient is going to feel any oddity, any pain, any discomfort, it's going to occur from getting up and off the table and walking to the treadmill. And this occurs primarily because of the reciprocal inhibition, where we can shut off the muscles of the lower back. It will feel odd, and some patients will describe like it's almost like their muscles, their back's going to go out on them, but as they start to move, it starts to reinitiate, starts to refire. This is part of the reason why the unweighted treadmill needs to follow the Vibro Trac table, because it will help to reinitiate the muscles at that point in time. So some of the things to keep in mind then as we come to a close on utilizing the vibration table is that there are several protocols that can be used on the table. You do not need to utilize each and every protocol for every patient. It is specific to the problems that they need. Think about and review the section that we talked about for disc herniations, what the theory is behind where would the wedging be if the patient has, say, a disc herniation that's going off to the right posterior side. Think about where that disc herniation will be, and that will guide you into what you need to do and how to set up the table. Think about what you're trying to do if a patient, say, has a radiculopathy and you want to gap open the side joints, and how that works. So continually review, continually practice on putting patients or one another on this. As the quicker you are with this, the less time it'll take to set up the patient and bring them through the protocol. The other thing to keep in mind too is that, remember, patients can have more than one problem. So we will always try to address the one that the symptoms match the x-rays or MRIs to begin with. However, if that does not resolve the problem, you can swap and do the other protocol to help the patient. The third thing to keep in mind is that with these protocols, if you set up and you start to do a mobilization or the traction bothers the patient on setup, chances are we've set it up incorrectly. The Vibro Trac table is pretty powerful in what it does, and one of the advantages of it is that if a patient feels pain or discomfort on that table while you're doing the work, chances are they're going to feel pain or discomfort down the road, like the next day or the day after. So we're probably doing the wrong thing. So continually ask the patient, do you feel pain or discomfort? Because when they're on the Vibro Trac table, it can be utilized as a guide to what we're doing. It can be an indicator that we've missed something or that we've set something up incorrectly. Hopefully this shed a little bit of light on how to utilize the vibration platform or the Vib table itself. The vibration table is really one of the most important pieces of everything that we do. It's also one of the most complicated parts, so we do recommend that you continually review and reread the material, as everything that we do in level 2 and level 3 will be primarily based on modifications that we can do to the table and the table setup itself. So please ensure that you're well versed in the way the setup is done and the basics, and be able to do it correctly regardless of whether you have the manual available or not. Thank you very much for your time, and we will look forward to having you at our later sessions.